changed. By definition, the first or second part of the popliteal artery is considered aneurysm where it is more than 1.5 centimeters in diameter. Popliteal artery aneurysm is considered the most common peripheral aneurysm, common in men, commonly bilateral, and in 50% of cases it is associated with AAA. Atherosclerosis is the main cause. Recently, degenerative changes were being investigated, and they seem to be one of the causes for this aneurysm. The aneurysm increased by 3 millimeters per year. 50% of patients are asymptomatic. The main symptoms are thrombotic ischemia, critical kidney defeat, or compression of the vein or the nerve. Rupture is very, very rare. The diagnosis is confirmed when you feel by the hand the popliteal artery, because routinely the popliteal artery difficult to be felt in this area by man. The diagnosis will depend on the ultrasound, CT, and MRA. The digital subtraction usually does not discover the thrombi in the wall of the aneurysm, because it only shows the lumen of the artery of the aneurysm. So the outcome is best in asymptomatic patient. Therefore, once the popliteal artery is aneurysmic, it should be treated. Even if the condition is asymptomatic, but we should treat. We are obliged to treat thrombosed, large, symptomatic popliteal arteries. 200 years ago, John Hunter has dilated popliteal artery, and after him, the canal was named. So the gold standard of treatment of popliteal artery is arterial bypass using reversed great saphenous vein with ligation of the aneurysm above and below, and this is usually made from the immediate approach. We sometimes resort to the posterior approach if the artery is very huge, and we treat it as the AAA by laying in a vein graft. If the distal branches of the aneurysm are thrombosed, we should routinely either do thromboembolectomy or thrombolysis. Recently, because due to the advancement in the technique of endovascular surgery, this became a model of treatment of popliteal aneurysm. But it requires to be achieved 2 centimeters at least in the neck and in the two ends of the aneurysm to have a fixed stent. The artery should not be very tortuous and not extremely large. And this is contraindication in persons who need to fix his knee more than 90 degrees all the time, or in patients which cannot tolerate antiplatelet for a long time. The stents used in this location are covered stents, either Viaban, Covera, or Fluency stents. This patient is a 75 years old man who I operated 2 years before stenting the leg for one side by the classical, traditional medial approach, bypass vein grafts. And the operation was, went very nice, and on the charge, I told him that he has an aneurysm in the opposite side, and he should come at least for 2 or 3 months to be repopulated. He disappeared for 2 years, and then came with a very huge aneurysm in the opposite side, and he came with he insisted not to be operated. So I said to Ahmed Naga, my first assistant, and he treated him by this, by endovascular, and he used 5 stents, 3 Covera and 2 Fluency. And this is the result of his technique. So the outcome treatment in open surgery is successful in 80% and similarly in endovascular. But the preference between open and endovascular in long term need to be investigated. Now, the home message is that the choice of open versus endovascular should be individualized. Second, endovascular shall be reserved for patients with good anatomy, do not require to bend the knees for an acute angles, and that tolerate Plavix for 3 months. Open repair remain the gold standard for at least for the Egyptian who cannot tolerate the financial burden of the covered stents. For the vascular trainees, they should acquire the skills of both modalities, because for this patient nowadays, they are asking for endovascular, so every patient should individually select it. This is the result of announced by the Society of Vascular Surgery in 2021 and published in Journal of Vascular Surgery, which showed that نص دقيقة ممكن نص دقيقة